to give brief comments before we proceed to the session. Nerli sir, President ASU. Nerli sir. Okay. As you all know, the Association of Southern Urologists is one of the largest urology group in India, and proudly recently we have crossed 2000 members number, and in which 1100 members are permanent members of the Association of Southern Urologists. We have been conducting the webinars regularly on a monthly basis on certain subjects. Today, we have taken a subject, open surgery, principles, the perils and practice. As you all know, open surgery is very important. At least in the era of laparoscopy and robotics, there are some complications in laparoscopy which cannot be managed by open. There are emergency situations where open surgery is indicated. There are conditions where laparoscopic ports may not be possible to put. So many such things can be discussed. As the time passes on, students who are trained with only laparoscopy and robotic surgeons may not know how to approach the hilum in emergency. So since long time, we had a feeling that our council had feeling that better to discuss such topics also. Nerli sir,
yes.
Can you give brief comments, sir, please?
Yeah, welcome to all the members of ASU and also the panelists. These are one of the subjects which it really requires to be looked at. The discussion was also done in the Association of Southern Urologists meeting regarding some of the cases where open surgery is required. I would now request Dr. Chandramohan to proceed on with the presentations of the various speakers.
Thank you, sir. Thank you, sir. I will briefly introduce the speakers. It is my privilege to introduce the senior speakers. Purposefully, we have taken seniors who have gone through the open surgery, laparoscopic surgery, and they may be experienced in the robotic surgeries also. This is our council, Rajendra Nerli sir, President, Jagdishwar sir, President-elect, immediate past President Dr. Changal Ryan sir, who is also with us, Dr. Chandramohan Vaddi, myself, Honorary Secretary, and Dr. Siddhilingeshwar Neeli, Secretary-elect, and Treasurer Nishchit D'Souza. Dr. Balgopal Nair, Kannan sir, Kumar Prabhu, and Ravi Kumar sir are the council members. Jagadishwar, Vinod, Shrikant Marwade, and Periyaswamy are the ex-officio members, the presidents. To start with, we are today. Expert panel member is Dr. N.P. Gupta sir, who is MBBS from Jabalpur, MS General Surgery from AIIMS New Delhi, MCH from Urology AIIMS New Delhi, currently Professor Emeritus Urology in Medanta Medicity, Gurgaon, having 50 years of experience in urology. I am just crossing my 49 years. He is more experienced in urology than my age. Expertise in open surgery, renal transplantation, endourology, laparoscopy in teaching institution. He is formerly professor at HOD, and I am also during my surgical training in AIIMS trained under his rotational posting, under our rotational posting. Dr. Jagadishwar is MBBS, MS, MCH, and from the Kakatiya Medical College, from MS from Usmania Medical College, MCH from Gandhi Medical College, currently professor at HOD ESI Medical College. He is also elect president ASU with 30 years of vast experience. Dr. Madhappa sir, who is MBBS, MS, DNB, MBBS from St. John's Medical College, Mysore, MS General Surgery from Mysore, DNB from Urology Apollo Hospital, Chennai, currently Senior Urologist at Sigma Hospitals, Mysore. He is formerly Professor and HOD in Urology from JSS Medical College, 35 years of experience with vast experience in general urology, renal transplantation, endourology, and laparoscopy. Dr. N. Muthulata Madam, MBBS, MS, MCH, MBBS from Madras Medical College, Chennai, MS General Surgery from Madras Medical College, Chennai, MCH, Madras Medical College, Chennai, currently Professor and HOD, Sabita Medical College, Chennai, having 32 years of experience in Tamil Nadu government service in various departments, MMC, Kilpauk, expertise in open surgery and renal transplantation in teaching institution. She is formerly Professor HOD in Urology from Kilpauk Medical College. And now Dr. Frederick Paul, MBBS, MS, MCH, Associate Professor of Urology, Government Medical College, Kottayam, 21 years of experience in open surgery, endourology, and renal transplantation. MBBS from Government TD Medical College, Alappuzha, MS General Surgery from Army Hospital Research and Referral, New Delhi, MCH Neurology from Government Medical College, Kottayam. Dr. Rajaraman sir T, who is also very senior, a well-wisher to all of us, MBBS from Government Jipmer Pondicherry, MS General Surgery from Madras Medical College, MCH from Madras Medical College, consultant urologist in Chennai, having 25 years of experience of open surgery, more so in renal transplantation in teaching institutions. He is formerly professor and HOD in urology from Stanley Medical College, Coimbatore Medical College, Tirunelveli Medical College, Tirunelveli. Before professor in Stanley Medical College, is assistant professor and professor in Madras Medical College. With this introduction, we will start without wasting time. Can you escape this? No, I wanted to switch over. Yeah. So my first question goes to Dr. Madappa sir. Dr. Madappa sir, you can unmute, sir.
Yeah.
Sir, in the present era of laparoscopy and robotics, in
Yeah.
your private practice, which surgery you will do open surgery, sir? Quickly.
Okay. I as a PG, I started with only open surgeries as far as kidney was concerned, including for renal stones, donor nephrectomy, and all type of renal pathology. But I think after the minimal invasive procedures which is taken over, uh, I also have changed. And I think everybody wants to do minimal invasive. That's the way patients also coming and asking for it. But there are certain surgeries I feel personally, and also it is good for every urologist to go ahead straight away with open surgery. First of all, the trauma. Trauma, of course, I don't think anybody can venture into with a minimally
Great.
thing,
Sir.
especially when the patient is in a critical stage, collapsing. We do trauma surgery mainly to save the patient's life more than the kidney. So in that scenario, I think you should take up all of them, open surgery, that too, supine position, midline incision, so that you approach the vessels quickly and then take care of the control the bleeding and then try to save the kidney. That is one. Next comes, I think, some of the infective pathology in the kidney, especially xanthogranuloma pyelonephritis, where the fibrosis is so much, the adhesions is so much, not only around the kidney, some of the structures like colon and duodenum will be so badly stuck. You'll not be able to identify sometimes the ureter, renal artery, or renal vein. And at times, it so happens that you cannot even remove the kidney totally,
Yes, sir.
zero. In
Yes.
fact, you have to go through the capsule. Subcapsular nephrectomy is a known phenomenon over here. So
Yes,
that
sir.
sort of surgeries, I don't think you should venture with minimal invasive and then get into more trouble. I feel even whoever tries that quite a few times, they must be going for conversion. Next comes malignancies. Some of the malignancies which are very large, infiltrating to the surrounding structures, and with large tumor thrombus in the IVC, not only abdominal, sometimes maybe extending to the thorax. Nowadays, I see some of the videos going ahead with robotics and then taking out all that. But I don't think it is necessary to do that sort of an adventure. It is most ideal to open up, secure the vessels, and then
Yes, sir.
try to remove the tumor.
Okay, sir.
And also, I would like to say that some of the small tumors around the hilum, where the surrounded by the blood vessels, artery, and vein, where you want to do a partial nephrectomy, I would definitely open up that particular patient and do a partial nephrectomy. I will be much more comfortable in that also, I think.
Okay.
And all minimal invasive procedures where you get into trouble, mainly bleeding, or you're not progressing with the surgery, you have to convert. There's no option.
Yeah, sir. So very crisply answered 5 things. Number 1 is trauma. Number 2 is large tumors. Number 3 is severely inflamed diseases like xanthogranuloma pyelonephritis. Number 4 is very small tumors at the hilum. Number 5, if you cannot do lap and rope, there is no other option except opening. Now, next question to Dr. Mutulata, madam. Madam, in the present, when the PGs join, in the MCH PGs join, what are the common positions you give in open surgery for renal access? Majority of the times, we do line approach and we do abdominal approach. Can you briefly tell what type of position you give? Leg straight, one leg flexed. This point, can you enlighten, madam, please?
Yes, sir. Definitely. We are going for a commonly for a flank approach only, sir. Either 11th rib bed or a 12th rib, according to what type of surgery we are going to do, either a pyeloplasty. Because as already sir told, all the PGs, they should be know about the open, how to go for a open. So we are giving them. So usually we are going for a flank approach only. So 11th rib bed. Yes, sir.
In the flank approach, to raise the flank. In laparoscopy robotics, we don't put
Yeah.
any 3-liter saline bottle or any folded towel. Do you routinely do that under the 12th rib? Do you put any support nowadays, or you use the kidney bridge?
We use the kidney bridge, sir. If it is not available, but we'll tell them some of the places where they don't have, you have to have this 3-liter bottle, how to raise it. And because we have to widen up that space in between the iliac crest and rib space, that way we do want all those things.
Yes,
So
madam.
with that, we are going ahead with the flank approach.
So the flank approach. Do you use cautery to cut the skin or not?
No, sir. But for the skin and thing, we are going for a usual. We are going with the blade, and after that, we are going with the cautery.
And also, when you cut the different muscles with cautery, do you separate a small plane with them, or everything you cut in one go?
With the muscles, no, sir. Subcutaneous tissue, then we'll go ahead with the muscle.
The muscles are separated in the each muscle is separated for suturing later on easily, or there is no need to separate like that?
Definitely, sir. External oblique, then we'll go along with internal oblique and transverse with the same thing, and we'll go ahead. So, because then only we'll have a 2-layer closure very easily for those things. So, we'll
Madam,
avoid the post-operative.
Madam, when you go to the kidney, if the PUJ obstruction, if you read on CT that it is low-lying kidney, will you avoid the rib incision, or still almost all the times you cut the 12th rib?
No, sir. We'll go with the tip of the 12th rib only, or the tip of 11th rib, so that we'll only, because we are going for a pyeloplasty, we are going for an anterior approach. So no, there is no need for the mobilization or anything.
Right.
So we
Yes,
don't
madam.
need for a rib dissection at all.
Madam, when you will give horizontal incision, when will you give a little downward incision, when will you give extended downward incision in the lion?
Or for if you, with the imaging studies, if we think that it's only an extra-renal pelvis, we can go for transverse thing itself is enough. Suppose if it is going for an intra-renal, or if we're going for a pyelolithotomy complex, then we need, because we need to mobilize the kidney and the ureter so that we can have an access easily.
Yes,
so at that time only, or for tumors, lower polar tumors, then we need an access.
yes, madam. Madam, when you are cutting the rib at the 12th level rib, what are the precautions you will take to avoid the pleura, madam?
So usually we'll tell them, you completely, you disconnect the muscles, so that how to periastally you have to be elevated. That instruments they should have periastal elevator and rib respirator, and how much they can go, because up to the angle of the thing where rib we can go, so that easily we can have a vascular control. So at that time, usually we'll pitch them the lower border of whatever rib you are having, that upper border of the lower rib should be the point of thing, so that we can avoid a intercostal vessels injury, that is neurovascular bundle, as well as the pleura. So when it comes, the pleura has to be slowly, it has to be mobilized upwards, so that they need not worry about the pleura.
Madam, when you give a little oblique incision, the nerves will be coming horizontally. Do you like to spare? I have seen some seniors during donor nephrectomy where they will identify the nerve. They will separate as much low down as possible so that your incision will spare the nerve.
Definitely.
And you like to spare the nerve and dissect?
Definitely, sir. Definitely. Yes, I'll spare, sir. So far, I never cut or anything, sir. Always I'll spare it.
Madam,
by a little downward traction, you can mobilize the thing without injuring the neurovascular bundle.
So when you by chance open the pleura, how do you repair, madam?
So if it is a smaller one, yes, with the 2-0 chromic, you can open it. If it is going to be at the angle, then it will be very difficult. At that time, we can mobilize that underlying muscle so that it will give a coverage. And if it is going to be a little bit more, then you have to press ICD. So it's all depends upon how much of thing.
Great.
If it's a very small, it need not have an ICD at all, and you can boldly you can close it and come out.
Great. Madam, if the pleural injury is big and if you are taking bite again and again, it is getting torn, then can we pack it up to the lateral abdominal wall gently and make a mass closure so that you don't disturb the pleura?
Yeah.
You other this pleura which is open to the wall. Is it okay?
Yes, sir. We can close it with an ICD, you can promote.
Yeah, ICD done. Very good point taken. Juniors, if you are having any problem, ICD insertion is minor procedure. So you do it and come safely. Madam, previously we used to put infant feeding tube, inspiration, expiration, slowly keep that in the water, and then air will be coming out. At the end, we pull it out and tighten the thread in a purse string manner. Do you do now also the same thing?
No, sir, no, we don't do.
We don't
We'll
do
ask
that.
them to give a positive pressure at the end of
And
the
then
thing,
close it.
adjusting, that's all, sir.
Thank you, madam. Frederick
Thank
Paul, sir. Hello, sir. Sir, in open surgery, when you are doing the radical nephrectomy, do you like to open the zerotas, or you will dissect on the psoas and directly go to the renal artery, sir? Unmute, sir. Frederick, sir. Hello, sir. Frederick, sir, we are not audible, sir. Yeah, unmute now. No, sir. Your mute, your voice sound should increase, sir. Hello. Sir, you can update the Zoom, sir. You can come back with Zoom so that it will come. Sometimes the voice will not come. Meanwhile, I will take Ravichandar. Come back to the Zoom, sir. Ravichandar, sir.
Good evening, Chandram.
Good evening, sir. Ravichandar is from Gandhi Medical College, HOD. Ravichandar, sir, when you open the retroperitoneum, first you will see the gerotas fascia and some fat on the gerotas fascia also.
Yeah.
When will you open the gerotas? When you will be outside? Do you like to dissect initially outside the gerotas or inside the gerotas?
This is for radical nephrectomy?
Yes, sir. Radical nephrectomy, sir.
We will go outside the gerotas fascia. We develop the plane between the gerotas fascia and the psoas fascia.
If it is pyelolithotomy, what will you do, sir?
If it is pyelolithotomy, we will just lift the posterior gerotas fascia and open the gerotas fascia vertically.
Sir.
Go and dissect the ureter, and we trace up to the pelvis. Then we try to do Gilbert dissection if it is pyelolithotomy.
Sir, if you open retroperitoneally, if you are not able to identify the ureter, what are the small measures you will take, sir? You wanted to trace the ureter for pyelolithotomy. How do you identify the ureter and how do you go towards the pelvis?
It will not be that difficult. We have to go in the plane between the posterior gerotas fascia and the psoas fascia, lift the medially and open the gerotas fascia there. Then you can find gonadal vessel and the ureter very easily. If you are going in the right plane and opening the gerotas fascia posteriorly, definitely it will not be a difficult task.
Sir, one important problem the juniors face is dense adherent fat, even laparoscopy, robotic, open, densely adherent fat. All the seniors might have seen in and out, but we have not seen because pyelolithotomy we have not done. By the time we came out, the PCNL was there very much. What will you do with the gerotas fascia inflamed around the pelvis? What are the steps you take, sir? Will you take cautery? Will you take dissection with right angle?
Yeah, we use right angle so that we lift the tissue away from the ureter, hold it, cauterize it and cut it. But you have to be careful at the lower pole, you might get a crossing vessel. And in that sticky fat, it is difficult to identify those crossing vessels or any other thing. So you have to be careful and dissect slowly, bit by bit, and dissect up to the pelvis. And it will be it will be really difficult to dissect the tissue, but slowly we can do that. But sir, you need to have patience for that. You have to dissect step by step.
Yes, sir. Sir, if you by chance peritoneum is opened, you are dissecting with finger anteriorly, roughly, and peritoneum is fully opened and colon is seen, and you are doing a nephrectomy, which is difficult. Would you take like to advantage or you close it and then go back to the plane?
Actually, whenever there is difficulty in especially XGPN or pyonephrosis cases, and finding it difficult to develop the plane between the colon and the kidney, we intentionally open the peritoneum so that we can separate the colon from inside and go on the IVC, so that we will be safe. We will be safeguarding the important structures IVC, colon, and the duodenum.
Yeah.
After that, then we dissect laterally.
Sir, do you think on the left side, right side, retroperitoneal access to the surgery, do you think incisional difference will be there, any horizontal or vertical incision? How do you like routine radical nephrectomy?
Left side, right side. No, not
I
for,
mean,
for
left side
incision.
and right side, line incision, what I mean to say, when you are doing right side radical nephrectomy, left side radical nephrectomy, will there be any change in the incision or no difference?
No difference, because the main important is going to the pedicle, and lower down we can just retract, we can extend the incision
Yes,
in
sir.
the same direction, and a common ureter gonadal pocket is hold, and plate is developed between the ureter and the aorta on the left side and IVC on the right side. Then we
Sir,
go up to the pedicle and manage it.
so there is no difference. If you are a renal transplant surgeon also doing donor nephrectomy, in donor nephrectomy, retroperitoneally we do you have any incision change? Which starting point to ending point incision? Where should be the incision?
We generally go on the 11th rib. So
11th rib,
on
take
both
all
the
that.
on
And
both the
to take
sides.
the as much as ureter possible, will you divert a little horizontally and then
Yes,
vertically like that?
for donor nephrectomy, we go a little vertically down,
You
so
always
that
take 11th rib, sir.
ureter
In
will be
donor
dissected.
nephrectomy, you take
Ureter
always
will be
11th rib.
always 11th rib, and we go because pedicle is more important in donor nephrectomy. Management of the pedicle is very important, and the incision will be directed a little downwards to dissect the ureter up to the crossing of the iliac vessels.
Okay, sir. Now, Rajaram, sir, unmute, sir, please, sir. Thank you, Ravichandra, sir. Unmute. Sir, do you have any experience in trauma? Any renal trauma, nephrectomy, how do you approach? It's a difficult question in terms of me, maybe your experience. Whenever in casualty in government institutions, trauma comes and patient is in hypotension, you have decided that after resuscitation you wanted to do nephrectomy because of the severity of the injury. What is your experience, sir? Please, Rajaram, sir.
My experience in trauma is quite a good amount. Patient, when it comes to casualty, I'll assess him general condition, sir.
Yes,
Our
sir.
general condition. First priority is build up his BP, check his hemoglobin, all the renal parameters, hemoglobin should be bought. Then you plan, do a CT scan, then you plan accordingly. Can the kidney be preserved or not? Two things, sir. Upon a grade of kidney injury, 1, 2, 3, 4, 5. For grade, I'll preserve as much as possible. And for grade 1 and 2, I'll go through midline incision, sir. And
Sir.
open the paracolic gutter.
Very
and
good.
open the gerota. Grade 1 and 2, I do a renal sir.
Okay.
I think I'm able to do.
Sir, if you wanted to do nephrectomy, will you go directly to the hilum, pinch and dissect anything, or will you go step by step, transabdominal, transperitoneal, going on the lateral border of the IVC or the aorta, or will you go directly to the hilum, preparing with the any vascular clamp like that? How do you?
I have gone only directly, sir.
Directly to the hilum?
Directly I have gone. I had enough, directly I have gone.
Directly you have gone.
Really, the most important thing is you should build up the general condition of pain. Never take the patient there.
That's fine, sir. That's fine. Sir, if the artery and vein cannot be separated in emergency of bleeding is there, what will you do, sir?
If you're not able to separate, this applies even for inflammatory pathology, inflammatory kidney disease.
Yes, sir.
You have to do a mass ligation and clamp, sir.
Yeah, there is no problem. People say that fistula can occur. I don't think in the literature, many people in emergency do the mass clamping and then do that. I think in case
So
of...
one more, sir.
Yes, sir.
Give me 2 minutes, sir. First question I want to answer. It is relevant and to know and perform open surgery in the present era. It's meant for younger generation.
Yes,
India
sir.
is a developing country, sir. It has got a wide spectrum. From patient point of view, poor to rich. Hospital, small, big and corporate hospital. Infrastructure availability. It varies from hospital to hospital, small hospital periphery. And open surgery can be learned easily and performed anywhere with minimal infrastructure. Open surgery can be learned anywhere, sir. Having worked in Tirunelveli, all periphery hospital, you can work. So younger generation should know.
Yes, the ultimate, the idea of the webinar is that only, sir. Sir,
Yes,
the
sir.
next question is, when you wanted to do nephroureterectomy for the TCC, what type of incision you prefer? Separate incisions are the lower end and separate incision for the upper end?
I'll always use separate incision, sir. One incision modification, I tell you, sir. I go through 11th transcostal approach.
Yes,
push
sir.
intercostal now with a touch forceps, push it down. Then I cut the diaphragms from attachment to 11th rib till I go to the crura.
Yes,
Very important, you have to incise the diaphragm from the ribs and in about till you approach the crural
as Muthulata madam told that the muscles to be released to avoid the injury.
Yes,
I think the
diaphragmatic
diaphragmatic
muscle.
attachments also carefully to be dissected down
Yes, sir.
and fill the
Diaphragmatic
rib
muscle.
completely
Yes,
so that you have a better retraction.
Yes, sir. Yes, sir. And one more thing, sir. Pleura should never be closed when the patient is on kidney position or thing. It should always be closed.
Yes,
When
sir.
you lower
At
down
the end of
kidney.
the end of the surgery, pleura
Exactly, sir.
closed.
Exactly. That's a good point, Ishwar. Thank you, sir.
Thank you, sir. Frederick Paul, sir. Now, in retroperitoneal.
Yeah. Am I audible?
Yes, sir. Audible, sir. Audible, sir. In retroperitoneoscopic adrenal surgery, what is the incision you are going to do, sir? Will you go 11th rib horizontal or what type of incision you'll?
Same incision. It doesn't make a difference. So I always do a flank 11th rib, either left or right. It's a 11th rib incision. It's possible to reach the adrenal.
Yes.
I have never faced any problem.
While doing adrenal surgery, would you like to open the gerota, see the upper part of the upper pole, I mean the parenchyma of the upper pole, and then start, or directly you will go to the adrenal posteriorly?
I'll directly go to the adrenal. There's no need to open the gerota. You can, if once the adrenal is enlarged, you can easily, once you reach the retroperitoneum, you can easily see the gerota. On the right side, take control of the adrenal vein. Somehow you clamp it, and that is the most difficult part of the surgery in both right as well as left. I stress the right side because the vein goes posteriorly, posterolaterally, it goes into the IVC. So early control of the vein is important. Left side, it is much easier because it is draining into the left renal vein. It is very easy to take control of that.
Sir, people say that in adrenalectomy, adrenal tumors, trans laparoscopy, I mean, through the laparoscopy, it is easy because especially pheochromocytoma, where you don't handle the tissue. Do you think that we handle the adrenal more retroperitoneally or more transperitoneally? Actually, by principle, renal and adrenal surgeries are retroperitoneal surgeries. But malignancies, teaching wise, they say that go to the ileum first before meddling. What is your take on that?
I didn't get your question.
Sir, will you approach the adrenal sometimes through the peritoneum, transperitoneal or retroperitoneal?
Laparoscopically, maybe transperitoneal will be the easier, but
Open.
always retroperitoneal. Unless and until the
laparoscopic method. Sorry, you don't consider transperitoneal.
Never. Unless it is so stuck to the peritoneum and it gets accidentally opened. Retroperitoneum is, I think, to me, it is easy.
Sir, do you recommend open surgery with a single incision transperitoneal in bilateral adrenal disease? Big incision like in what we give in Whipple's pancreatectomy type of incisions. Are they given nowadays in urology?
Chevron may be, rather than two flank incisions, chevron may be the acceptable option.
Yeah. Okay. Sir, now I will request Dr. N.P. Gupta, sir, whatever the topics we have discussed, can you briefly in 2 minutes tell your opinion? Opening, positioning of the patient, pleural injury, neurovascular injury, opening the gerotus fascia, the identification of difficult the pelvis, and the identification of the renal vein and renal artery injury when it happens, and adrenal surgery. Some tips, please, sir. Dr. Gupta, sir, is very senior. Unmute, sir, please.
Okay, can you hear me? Yeah, I'd like to thank ASU and for inviting me as an expert for this panel. And whatsoever I have heard, I think so all the panelists have excellently described most of the typical points which has to be considered during the open surgery. Now, in my career, I started in 75 in All India Institute of Medical Science. For first 30 years, I used to do all kind of open surgery only. In 95, we started laparoscopy, and 2006, we started robotic. So I have got experience of all kind of surgery. Even today, in the era of laparoscopy and robotic, I think so there is a big role of open surgery also. Now, it is initially wherever we see a patient, we have to open, but it is not like that today. So the judgment and the wisdom of the surgeon is very important to select out a patient, which one he like to do open, which one like to do laparoscopy or robotically, because there are certain procedures which have been better outcome with each one of the type of approach. Now coming to the incisions, I think so in open surgery, we should not compromise with the size of the incision. It doesn't make any difference whether you have 8-inch incision or 10-inch, because healing time is same, and stretching of the muscles is not to be done too much. If you are doing too much of stretching, there's a lot of post-operative pain and recovery, and also chances of the hernia is more. So it is better to have a larger incision than going through a small incision and struggling all the time. The other thing is the learning curve also. I think so. I like to just continue with that discussion of the open laparoscopy robotic. Now, they said, you have to learn the procedure, and there's a big learning curve in laparoscopy surgery, maximum, I will say, and then also in robotic surgery in comparison to the open surgery. Therefore, it is very important for all the postgraduates that they should have experience of the open surgery. There is no doubt about that. And you have already heard the indications when you have to convert also to the open surgery. So until unless you have experience in open surgery, you may land yourself into a big difficulty. So that point is very clear that every trainee has to learn the open surgery.
Great, sir.
The other thing is one thing I have heard about the identification of the ureter. So I like to add only 2 points. If you are not able to find the ureter, you can dissect down, go up to the iliac artery and start searching the ureter from there, and certainly you will get the ureter, because that is the one fixed point where ureter crosses the middle of the iliac vessel.
Even in the retroperitoneum, this will help, sir. In the retroperitoneal surgery also.
Yes.
Great.
When it is difficult to find out. One thing was discussed about the inflammatory thick pelvis and dissection in that area. I think so. The main important point is whenever you are cutting in that area, your incision should be vertical. Never cut transversely. If you cut transversely, there are more chances that you may injure the ureter. So that is the one thing which we always remember, that we have to dissect vertically only and try to find out the ureter and pelvis by making a vertical incision. And I think so rest of the things you have discussed very well. I don't have to add anything more.
Yes, sir.
But approach, which one to select, I think so you should know the what is your target.
Yes,
and
sir.
your incision should directly be on targeted, whether it is subcostal, intercostal, 12th rib bed, 11th rib bed. I think so it all depends upon which pathology you are doing. If you are doing upper polar tumor, you have to be a higher one. If you are doing a lower polar tumor or pyeloplasty, your incision has to be lower. So that selection of the incision has to be according to the patient. And we have already heard that chevron incision is very good if you are doing a very large tumor or something like that. And one thing more approach in, especially in the cancer surgery, radical nephrectomy, if you have a large tumor with IVC thrombus, then better to go to the artery first, actually, between the aorta and vena cava, instead of finding out the artery in the native places. Otherwise, there can be more difficult for you to reach there.
Yes.
And one thing more I like to add here is that in case of large tumor with collateral vessels, which you can see on your CT scan, pre-operative embolization is still has to be done maybe the previous day, and next day morning you can take up these cases for surgery.
Correct.
So, Chandramohan, this is in brief I'd like to add.
Thank you, sir. We will take again one more round, quick round. Madhav, sir, again we'll start with you. Sir, the discussion of open surgery pain. To avoid this pain, do the nerve block at the end of the surgery has made meaning, or subcutaneous we used to give, muscles we used to give. Do you follow that, sir? What?
Yeah.
You give brief comment on that. We'll have only one question. We'll move faster. Yes, sir.
Yeah. I have been doing that regularly. We use diluted sensorcaine and block the subcostal nerve, the one which is in line, and also in between the muscle planes, especially the internal oblique and transverse abdominal plane. We inject into that plane also. The results are very good. Patients have been definitely comfortable. One more thing I always use is that sometimes our anesthetists give the epidural for pain management, and then we maintain that also, depending on the significance of the incision, large incisions.
Sir, do you believe that if you give injection properly between the internal oblique and transverse abdominis, where the neurovascular bundle
Yes.
will initially stay, you need not give a large area of muscle. Do you agree,
Yeah,
sir?
exactly. I always give in that plane only,
That plane at the base
not
of the
anywhere else.
spine, at the posterolateral aspect, at the rib level, if you
Exactly.
properly inject, so the muscle need not be given, but the
Yeah.
nerve, intercostal nerves supply is different. So
Yeah.
sensory nerves, you can
Yeah.
give the local to the skin at the end of the surgery.
Exactly.
Fine, sir. Now we will ask Dr. Mutulata, madam. Madam, in open surgery, there is a controversy that retroperitoneum, when you handle more, paralytic ileus will be there. In the post-operative period, patients will have vomitings and all these. What are the things which are important when you are doing open surgery to avoid post-operative ileus? I know it's a vague question. Whatever your senior
Usually
expert.
we don't get, but only thing during, because we used to do donor nephrectomies often.
Madam.
So at that time, when we are going for a right side, we will be having a retraction because the duodenum and the thing we need to retract, because then only we can go ahead with the IVC and dissection over that. So at that time, we have a patient may have a paralytic ileus. But usually, unless the patient has, then only we'll put a rise to aspiration and all. Otherwise, usually we don't put it.
Usually, retroperitoneal surgery does not cause.
It does not cause paralytic
You don't
ileus.
need to put the nasogastric
Yes, sir.
tube. How often you start orally by 8 hours most of the times?
Definitely, the next day morning we'll start.
Next day morning you'll start. Very nice, madam. Ravichandar sir, in the
Yes, sir.
In the donor nephrectomies, when you do open surgery,
Yes, sir.
when only one kidney is there, what type of analgesics you will use, sir? Will you use only crocin? Nowadays, everybody
Yeah,
says
only paracetamol
only
we are using.
paracetamol they will use.
Yeah.
But a lot of the patients will complain of pain on the first day. Apart from the nerve block, will the tramadol or diclofenac is one dosage is also not recommended, because diclofenac we have given in and out for 1 or 2 days. Now it is projected as the poison. What will you say, sir? Will you give if the severe, because it acts very well?
Generally, we give tramadol in addition to paracetamol.
Yes, sir.
Otherwise, we are not using.
You are not using.
Exactly.
Sir, if there is any spillage in open surgery like pus or too much contamination, what are the precautions you will take to decrease the wound infection in the post-operative period?
We irrigate the area with a lot of saline. And
Betadine saline you use, or normal saline, or amikacin or gentamicin mixed saline, anything like that?
yeah, betadine saline.
Betadine
Nothing
saline.
more than that. And we
Generally,
use
what size bore the drain you will keep for in such cases? 30, 28, 26, 24?
Frank pulse, we use 24 French.
Yeah, 24 French.
Yeah.
Frederick Paul, sir. Sir.
Yeah.
Sir, during a pyelolithotomy, which is very important question, during pyelolithotomy, when you dissect the pelvis, if the stone is in the pelvis, in addition to some of the stones in the calyces, what type of incision you will give on the pelvis? Will you give horizontal incision, oblique incision, or vertical incision, so that your maneuverability is better?
Normally, I use a V-shaped incision, the apex of the V towards the
PUJ.
PUJ. Away from the PUJ towards the PUJ.
Yeah.
Both the limbs, one towards the.
What is the reason, sir? What is the reason?
Because the access will be good and the inadvertent injury to the PUJ is avoided.
Okay.
You can manipulate the pelvis. You can even enter the calyces, and if you require a extended pyelolithotomy, it is easy to make a radial incision onto the calyx and you can take out the stone.
Okay, sir. Now we'll ask Rajaraman, sir, again, who is experienced in open surgery. Sir, in the era of peak open renal surgery, what are the common problems? See, what I remember, when you put the stone holding forceps through the pelvis, you don't have any visual. You always feel and take it out. What are the tips to take out the small stones? What are the tips to take the large stones? What are the tips to identify whether you have completely removed? Can we use CIAM in the open surgery? These 4 questions you address quickly, sir.
One thing, sir. This was the era before intravenous urogram used to be there. So we used to study pre-operatively what size of the pelvis, the calcium stone. We had to be prepared for all these options, sir. See, suppose there is extra calcium stone which is larger in size. So we should plan prior. Those days, no CM was there, sir. Only X-ray KB. Pre-op planning is must in those days.
Sir,
So
if the stone volume is high, do you recommend complete mobilization of the kidney so that you can hold it and feel it and take it out, or is it not necessary?
Yes, sir. It better to mobilize the entire kidney and as Chief says, you make curvilinear incision so that it doesn't extend into the PUJ,
Yes,
and so that you can extend the lower calyceal stone and remove the stone in the lower calyceal stone. Suppose stone is very small, you can put infant feeding tube. Best thing, mobilize the entire kidney. You can put infant feeding tube, wash the small calyceal stones, sir. If it is big, what I'll do is I'll make a radial nephrotomy, remove the stone, calyceal stones.
Sir, one tough question, sir. When you are doing this procedure, when you are manipulating blindly, and when something you have pulled out and suddenly bleeding occurs, severe bleeding from the pylotomy, what will you do, sir?
Sir, best thing is pack it up for some time, sir. Pack it up. You should wait patiently, sir. Patience is the best virtue of all surgeons, sir. You have to patiently wait. Then where's the bleeding, we should know. The arterial, venous bleeding. If it's so severe, then we have to look for where site of bleeding. You should be prepared for even having a tough surgery. You should be prepared for clamping the renal artery, eye slush, everything, sir. You should be prepared for large stone. All the complication is best is planned before itself, sir.
Sir, in this context, if any disaster happened during the stone removal, medico-legally we are unsafe.
Yes,
any precaution, like any large stone, do you recommend nephrotomy when you feel with your hand, when your stone is felt? Can you do nephrotomy and remove safely instead of meddling from below? And second thing, how to avoid avulsion of the ureter while manipulating these large stones intracalyceal?
The best thing what I do is make a radial nephrotomy. I palpate the stone, make a radial nephrotomy and close the nephrotomy wound, sir. After putting a double J stent. Nephrotomy is best. Not to put those days we used to have the angled stone forceps, sir.
Nowadays, X-ray QUB is not used for open surgery. X-ray QUB is very, very important. Do you recommend all cases X-ray QUB in open surgery?
Yes, sir. You should do.
Yes, you should do it.
Because then you keep in the lobby, you know where exactly the stones. Good X-ray QUB is must. And before operating any surgery, sir, stone surgery, the X-ray should be in the lobby, sir. So know the stone size, how much stones, number of stones, have you removed all the stones, the stone anatomy and structure, number of stones. Best study by X-ray, good X-ray QUB, sir.
Yes, sir. Quickly, Dr. NP
On the day of surgery, sir, especially.
Yes, NP Gupta, sir, quickly give the comments, sir, on these small topics we discussed. And of course, Jagdishwar, sir, has joined. Both of you give quick comments, 2 minutes. We will go to the next session of the
comments which have been made about the stone surgery. I think so. We have done a lot of stone surgery.
Yes,
and
sir.
I personally feel that stone surgery was the most difficult surgery because you have a challenge of clearance of all the stone, which sometime may not be possible. And one thing, what nephrotomy, I agree with him. Instead of mandling through the pelvis and going into the calyx pattern, you can palpate and you can make a radial incisions and take out the stone. And you can close all those incisions very well.
Yes, sir.
Other important thing, what you want me to, I don't do transplant.
Sir, nephrostomy after doing pyeloplasty, did you ever put nephrostomy after pyeloplasty in your best open times when endoscope is not at all available?
In the children, I think so. And whenever we put at that time, double J stent used to be not there actually.
Yes, sir.
At that time, we always used to put a ureteric catheter as well as we will put a nephrostomy catheter. There's no harm in putting a nephrostomy.
Yes, sir.
And in children also, we have to put a nephrostomy catheter in.
More safer. Jagdishwar, sir, quick comment, sir. Yes, sir. Now we will go back to the next round of question to Madhappa, sir. Sir, Madhappa, sir, if you have a question asked, congenital congenital is a theory question. I don't want to go into the depth. If you have a combination of PUG obstruction and UVG obstruction, what is your principle, sir, generally? If you are not in the era of endoscopic surgery, laparoscopic surgery, then it is a little tricky whether you do at a single setting, whether you do one by one or both together.
I'll do one by one. I won't do both together.
Sir.
Probably I'll do the PUJ first and then go for the UJ later.
Yes, sir. Okay. Sir, when you wanted to give 2 incisions, do you make a small incision and struggle, or you don't want to compromise in the incision? As NP Gupta sir said, in open surgery, retraction pain is more than incision pain. So do you believe in long incision, quick, neat, clean surgery, or something digging slowly here and there, assistant will not see that type of surgery.
Incision should be adequate. As sir
Right.
said, pain
Sir.
will be much more, and hernia also is more common because ischemic necrosis of the muscles.
Yes.
But for nephroureterectomy, I always put two separate incisions, significant incisions for kidney as well as a small incision down below near the bladder, so that that long cutting of the muscle is not necessary.
Yeah. Butulata madam, what are your precautions to avoid hernia when you are closing the abdominal wall? More so, muscular line approach where muscles are cut, a significant large bulk of muscles are cut. So, what are the precautions you tell? What are the suture materials you use for closing of the abdominal wall? A simple question, madam. Don't mind. But lot of audience are there. Probably 120 audience on webinar is a huge audience. So please don't mind.
Usually we close it on vicryl only, sir.
2 layer or 1 layer or mask closure?
Always 2 layers, sir. Always 2 layers.
Both layers vicryl.
Both layers vicryl.
And do you use any time interrupted sutures in any infected cases or all cases closed?
Very rarely we will go for interrupted sutures.
Why you are not using Prolin, madam? Because they say that the ischemia, the traction on the tissue will be less in a monofilament suture.
Never use that.
Don't feel any. What size of the 1020, madam? Large needle?
10 large needle, sir.
10 large needle. When you are going at the angles where the peritoneum is very close to the abdominal wall, what are the precautions? Do you dissect with right angle a little bit of the muscle, make a space and then proper bites, or the not necessary?
No, sir. Definitely we have to make a dissection at that place, and so that we will not injure that things.
All the closure has to be done off after removing the bolster and after straightening the.
Definitely after straightening the kidney bridge has to be completely down, and you have to take off. If you are going to have bolsters, you have to remove it. Then only we can have a tension-free.
Tension-free.
Yeah.
Madam, when you come at the distal, towards the rib side when you are suturing, the muscles will not be that much, and you have to suture with the external oblique more well formed there. There you cannot do in 2 layers. Will you stop at the tip of the rib and make 1 layer only from there?
Usually, I'll go from the rib side, sir. The first suture itself, I'll go from the rib side only, so that I'll come to the middle, and then again from the peritoneal side I'll come. So in between, so that usually you can have. If you are unable to, then you can have a 1 layer closure at the end of the ribs.
Yes, madam. Thank you. Frederick Paul, sir. In children less than 5 years, I am talking, not about adolescent children. In children, during the position, what are the precautions you take? When you are giving incision, people usually say that don't give big incision because they suffer, they are growing muscles. And pyeloplasty is the common surgery which we do. And pyeloplasty nephrectomy is the second common surgery we do. What are the things any different in children, sir, Frederick, sir?
You don't require a big incision because the muscle is pliable.
Yes,
you
sir.
don't need a rib cutting incision. You
Yes,
can
sir.
go just anterior to the rib. And since the muscles are not well developed, you can easily retract and complete your surgery.
Yes, sir. Sir, Ravichandar, sir, you are in the training institute.
Yeah.
If you are doing only PCNL and RIRS, if you are not finding cases, any open pyelolithotomy and ureteral lithotomy, how are you managing nowadays? Will there one time comes where all corporate trainers will request the government institution to train their students open surgery? Because if you are training only corporate training, and if you don't know suddenly bleeding occurs, and if you don't know properly where is the gerotas, where is the renal artery relation, what is the message to the fresh postgraduates which we join in your institute? Gandhi Medical College is a very famous, grand
Yes, sir.
old medical college. And how do you get ample open cases nowadays?
We are not that lucky to have laser, sir. So
Okay.
even now we are doing lot PCNLs, pushback PCNLs, mini PCNLs, and majority of the impacted stones in the ureter, we are doing laparoscopic ureteral lithotomy so that our PGs get trained in laparoscopy, reflecting the colon, reaching the ureter, identifying the ureter, and doing ureteral lithotomy. Now, and as per your question, we
Sir.
actually even for pelvic calculus, we post few cases for open surgery so that bees get exposed to it. That gluteal dissection, extended pyelolithotomies. We are not doing anatrophic nephrolithotomy for the reason that we are comfortable with PCNFs. And I don't think anatrophic is really.
What
It
is the
really
common
anatrophic.
indication of open surgery in your institute in a monthly statistics?
Common indication is pyonephrotic cases,
Yes, sir.
certain XGPN cases.
XPN.
XGPN, yeah. Those are
Thank
the
you, sir.
cases. Thank you.
Rajaraman, sir. Now I will take a common subject, ureteral lithotomy. When you are facing a lot of difficulty in identifying a large ureteric stone, after you can only feel with your finger, tons of inflamed fat is around. What is the initial step so that you will not jeopardize the vascularity of the distal and proximal ureter and you will go on to the point? What are the precautions to reach the large impacted ureteric stone area?
First of all, we should keep a plan properly. Where is the ureteric stone? Upper ureter, mid ureter, lower ureter. If you adherent to that,
I will interrupt, sir. Traditionally, when we used to teach early morning, X-ray KUB is indicated.
yes.
Do you feel that in a medium stone which can migrate, when you are planning open, better to have one at least screening X-ray in the morning and then
Yes,
do
sir.
surgery?
Yes,
You are
yes.
believe in it?
Definitely, sir. You should have one X-ray.
You proceed with the next.
Now, what we do, sir?
Sir.
If you think adherent, depends on which approach. Suppose it's higher upper ureter. Actually, again, I'll go through tip or 11th rib. Number
Yes,
one.
sir.
If it's mid ureter, again, I'll go a flank incision. Lower ureter, Gibson incision.
Yes, sir.
Most important thing is you have to go to the virgin area of the ureter first, sir. You
Yes, sir.
catch the virgin area above the stone, hook the ureter, then you trace down. You'll be more careful that you will not injure adjacent organ. You have
Yes,
to
sir.
go to the upper virgin area of the ureter, sir. Either upper part or lower part, preferably upper part, so that doesn't migrate. Sometimes stone, as you inside, it might migrate. So always hook the upper part of the ureter.
So you mean to say you circumferentially you can take control with the feeding tube?
Yeah, you can do in feeding tube or umbilical cord.
Umbilical cord, which is
That you can do. Then slowly dissect, sir, and you feel the finger. Most important, you go to the virgin area. Never go to the stone directly, sir. You're able to feel. It might be something. Sometimes it can be in calcified aorta, calcified external iliac artery. People have mistake. Catastrophe has happened, sir.
Sir,
You are always trace
is,
ureter.
when you cannot cut the ureter on the stone without seeing the wall, is it okay to use the cautery and hold the stone, cut directly on it? Is there any harm, or you have to carefully dissect all the fat, make some space, see the adventure of the ureter, and then only cut? What you or
You are giving the correct
will
answer.
directly
I will
cut
see the
over the
ureter,
fat?
sir. I will not do that. I
You
will not
do that.
I will cut the adventitia, see the ureter. Not only for that purpose, you can easily pass the stent also, sir, up and down.
Sir, last
Never
question.
cut blindly, sir.
If by chance, if you cannot pass distally the stent or feeding tube in the theater, all you have tried, flushed with saline, everything you did, you could not pass. This might have happened with open surgeons very commonly because
Yes,
RCP, retrograde access are not there. What will you do, sir?
What I'll do, sir, I'll take infant feeding tube, sir.
Sir.
I'll use infant feeding double gesture. I'll insert infant tube down. I'll aspirate. If urine comes, I'm sure it is in the bladder. I'll pass infant feeding tube up. It's a commonly we use.
It is not going, sir. I'm asking. You don't have access below. Later on, you can assess. You have to come out of the theater. What will you do? Otherwise, it will leak.
I'll close and comes and pray.
You pray. You don't want to put nephrostomy or...
No, I will not do, sir. I'm very at my closing the ureter. I definitely close, sir.
I mean,
and
this question is more useful
goes.
in the absence of CT. There are many occasions IBP and CT. IBP is done, CT is not done, where contrast is not going done. If you have one more stone in the lower ureter, you might have all faced. We are not facing.
Yes, sir.
In that case, you will close it and come out.
No, sir. That's why I plan properly, sir.
Yeah.
The plain X-ray, the lower ureter, I'll think of the problem.
Yes,
if it is two stones, I'm not able to pass, and upper ureter, then I'll keep a nephrostomy, sir. Each individual stone disease is planned accordingly, sir. That the day of X-ray, plain X-ray, that particular day. Double stone. So the down stone is usually be smaller, sir. Upper bigger. So you usually make the bigger stone away. If your infant feeding tube is not going, then I'll definitely keep a nephrostomy, sir.
Yes, sir. Thank you, sir.
Chandramohan,
yes,
can
sir.
I interrupt here? in this situation, will you like to do cystoscopy and RGP before going for ureteral surgery?
Yes,
And
sir,
check
yes.
the lower
Yes, sir.
ureter whether
Must-
it is
In the
patent.
present era, before giving any such a major open surgery, we will
We should do
definitely
so.
like to assess the RGP, sir, please. Jagdishwar, sir, please, sir.
Chandraman sir, one minute. See, though it is open surgery, we take the help of ureteroscope, sir, in such sort of situations you were describing. So whenever a radiolucent stone is there down below in the ureter, and our guide wires and even the infant feeding tube may not go at times. So such sort of situations, we take the help of ureteroscope, sir. Ureteroscope,
Yeah.
pass it in and see and
Sir, in the
according.
present era, open ureteral lithotomy is less. You can use flexible scopy, you can use rigid ureteroscopy, fine. I'm talking about when somebody is doing in a small periphery and he is doing open ureteral lithotomy has done, he could not put a stent. Sometimes UVJ will be kink. There is no mechanical obstruction. In that case, if you leave also, okay. The youngsters may not have so much ease in putting the guide wire and all. That's why I raised this question.
In
Now
such
we'll go
a
to
nephrostomy one has to give.
yes, nephrostomy also safer option if it is upper ureter. But again, nephrostomy putting through the ureteric incision with an artery forceps may be very difficult. It may avert and it may tear and it may extend the incision. As Rajaraman sir, sometimes benefit of doubt later on you can see this way. And do you put the drain in ureteral lithotomy or not, sir? Rajaraman sir.
What?
Unmute, sir.
Surgery, sir. Open renal surgery, that renal tumor, pyelothotomy, I will definitely keep a drain, sir.
Yes, sir. Sir, Gupta, sir, quickly conclude about this small question, sir. Next,
No,
we'll
actually,
the final round.
Most of the things have been covered very nicely, and the tips of the trade has been given by the experts in their respective areas. They have very nicely explained. I think so. Even in the current era of laparoscopy and robotic surgery, it is very important that we should have the exposure of the postgraduates to the open surgery also.
Yes.
And once in the teaching hospitals, in government hospitals, I'm sure a large number of patients of trauma will be coming there. They will be seeing the open surgery. Large tumors are coming. Still, we see 10 centimeter, 15 centimeter large kidney tumor. And there, I will say, instead of struggling 2-3 hours with the laparoscopy robotic and then converting into an open, better why not to start with the open only. So that judgment has to be there with the surgeon, whether he can achieve that job or not. Reconstructive surgery also, if you are not very good in laparoscopy, better don't embark on that. Why not to go for a open surgery? That is
Yes,
more
sir.
safe and more outcome can be much better, like open pyeloplasty also has been
Yes.
done for so many years now.
Yes, sir.
So like that, I will say this session has been very good. All the experts have given very good points. And my hope is that the postgraduates should be benefited from this webinar.
Sir, next round, last round of questions, sir.
Oh,
Because we
still
kept
one more
for
round.
we will go for one more round. Sir, this is the last round, around 10 minutes, because we kept 1 hour. Anything beyond 1 hour will be boring online. Still, more than 100 audience are there. Dr. Madhappa, sir.
Yes.
Sir,
Yes.
when you go for open surgery, major radical nephrectomy, do you checklist is always there? Do you
Yes.
keep some retractors, instruments, the vascular sutures? Sometimes 50 in laparoscopy, it is projected so much that safety 10 centimeter stitch is rescue stitch is taken.
Yes.
In open surgery, all these things are essential. What is your comment before going for a difficult radical nephrectomy?
Yeah, no, when you go for a difficult radical nephrectomy, you must be prepared for a vascular accident. That's the most important and dangerous accident which can happen, and there's no time also. So if you are not well versed with vascular handling, you should have somebody who's good at it, approachable. And all the material, like especially Prolene suture materials, 5060, Satinsky clamp, all the vascular clamps, vascular forceps, they're all necessary, especially when you expect injury to the IVC, major vessels like that. And otherwise, the routine instruments for
Sir, in vascular suturing in your training,
yes.
anything like AV fistula, it is always better if you have had training, or else go to a one center after MCH. People are going only for RIRS, or going for only robotic or uro-oncology. whether you are in any branch, if a external iliac artery is injured, it's torrentially bleeding. If you have put your finger, if you are in a periphery where if you can take 1 or 2 stitches, it will do the job.
Yeah,
But
I
if
think.
that cannot be done with 5-0-prolin, is it not a big hurdle for your surgical career?
Yeah. AV fistula is the best way to train
Yes,
a
sir.
postgraduate for all vascular surgeries. In fact, when I was doing my residency, cardiothoracic surgeons, PGs used to come and ask me to allow me to give them AV fistula chances, because that's a place where you take your own time and do a fistula. You learn so much about vascular handling and suture handling. So I think everybody should be trained in that. And if
Yes.
you can do very good AV fistula, you can do transplantation.
Correct. Now, second question to Mutulata madam. Madam, important question. Subcapsular nephrectomy. Many of the youngsters might have not seen. When they see also, they don't see anything. The finger dissection boss will do, and somehow will clamp somewhere, and he will remove it. What is the concept behind subcapsular nephrectomy in xanthogranulomatous pyelonephritis or in difficult situations? How it can be done?
Recently we had the thing said, because we thought we can able to take it through laparoscope, but it's not so, because the pannus and the fibrous tissue is very hard, because he may not be able to break the tissue at all, and the anatomy will not be clear at all, especially on the right side, because IVC everything will be stuck up at that time. Suppose then at that time, definitely, because usually we'll go from a virgin area, like from the ureter, because definitely ureter will have a virgin area load, and from there we can trace it up. In case when everything's adherent, either posteriorly or anteriorly, because definitely a duodenum and everything has to be safeguard. So at that time, we have to go for a subcapsular nephrectomy. Usually, we'll teach our all the students, all the batches, how to do a subcapsular nephrectomy.
Madam, in subcapsular nephrectomy, we open the capsule, we dissect all around.
Yes, sir.
Most of it is done with finger dissection, and
Yes,
you
definitely.
specifically don't look with the artery and vein initially. In
Yes,
some
yes.
occasions, long artery forceps properly controlled superiorly without injury any other organ, you will clamp it. Will you ever try to separate artery and vein in subcapsular, or there is no need?
Sir, if you feel that pannus is not very thin, then at that time you can go for a separation of the vein. Otherwise, no need, sir.
Madam, if you have a long pedicle, you have clamped a long pedicle, you cannot do a transfixation stitch with silk. Is there any role of continuous vascular 3-0-prolin on the two
Yeah,
clamps?
usually it will be done.
Remove one clamp and do
One
it.
clamp, another clamp, 5-0-prolin will use to stitch it, sir.
You do. That is very helpful to,
Well,
and you do in 1 layer or 2 layers, madam?
two layers, sir.
2 layers. Great. Now, Frederick Paul, sir.
Yes, sir.
Sir, if you get a call that during laparoscopic nephrectomy, sudden bleeding has happened, whether you are doing or somebody else in the next theater is doing, and you have to open, how do you approach first, and how do you tackle the situation? If it is nephrectomy, it is fine. If it is partial nephrectomy, if you have injured the vein and artery, I know it is technically challenging. Your opinion I want, sir. Less often people may face this, but if you face it, it's life threatening. You cannot wait for a long time. What is the
Try to take control, go through the 11th rib. You open for any renal surgery.
Laparoscopy, when you are doing, you will open through peritoneum or retroperitoneum better?
Peritoneum only. You have to do transperitoneum.
Transperitoneum, yeah.
Go inside, and if it's possible, take a vascular conduit. If it's possible to repair if you can identify the injury, renal vein, renal artery, or IVC, whatever is that, try to take a vascular conduit. If possible, repair it. Otherwise, if it's beyond control, then go for a completion nephrectomy.
Again, when you do nephrectomy, if you have not taken consent for partial nephrectomy or pyelolithotomy, torrential bleeding from renal vein, uncontrollable BP loss, I don't know, Gupta sir will ask at the end. In medical legally, should we inform the attendants and do, or should we call somebody experienced to repair, or what is at your level you may not require, but for a junior, if he does nephrectomy in periphery, people will not take it easy, and tremendous pressure will be there. So what is how do you?
If you are doing this kind of challenging surgery, a large tumor or a large stone and all that, I think so you should, while you are doing the consulting with the patient, counseling of the patient when you are doing, you
Yes,
have
sir.
to tell them, and you have to ensure that there is a other kidney is normally functioning or not. If
Yes,
you are
sir.
embarking on surgery, that is very most important thing. And I will again reiterate that a functional study should always be done. Now, I have seen a lot of persons are now doing non-contrast CT and straightway go and operate, and suddenly they find that after the surgery, the kidney function is only 10% GFR. And then I start asking them, what was the pre-operative? They said pre-operative it was never done. So how
Yes,
do you
sir.
know the function is already not compromised? So from medical legal point of view, you should ensure that the other kidney is normally functioning. It is not a single functioning kidney. We have seen accidents in ectopic kidney, single kidney, like a ureteral or something. They have done a nephrectomy, like that.
Sir, is
So
it not that you have to keep a very senior of local region always as your godfather, call to that surgery, pay him, respect him, and keep in the theater when you are planning in a small periphery, I mean
it,
town, I mean to say.
it depends upon surgeon to surgeon, and surgery is a teamwork. One should not think that he alone can do everything, whether it's a open laparoscopy or robotic. So it is a teamwork. So you should have one good assistant who should be equally senior or good experience with you, or you can call as another senior person as a mentor. That is same happens in robotic surgery, and everywhere we have got a mentorship. So you have to call somebody senior with you. Second thing is for this vascular injury and all that, I think so, and gastrointestinal injury also like colon or duodenal injury, you should always call that specialist in your theater. Whether he will at least make a note that you have called him, he has also done his level best and he could not achieve the result. So
Yes,
that
sir.
has to be documented on the file. That is to save you from medical legal point of view. And if you should always take a consent, as I said, in difficult cases for the
Yes, sir.
nephrectomy.
Sir, yes, sir. Ravichandar, sir. Sir, if during a difficult nephrectomy or any renal access surgery, if the renal vein is injured before the renal artery is seen, if the renal injury, it is also a difficult situation. It continuous bleeds. If you suck, the blood will come out. If you leave it back, again it will bleed. How to get quickly the renal artery and then get control? Any suggestions on that?
If renal vein is injured before the renal artery ligation, in open surgery it is easy. You can put a compression on the vein
Correct,
where
sir.
it is bleeding and dissect the artery separately and try to ligate it. So in open surgery, the things are under control because your hands are helping it. So you need great assistance in laparoscopic surgery, but in open surgery, any accident can be tackled with your fingers, and you can apply clamp. You are worried about the turgidity increases when you apply cross clamping of the vein. So you can apply bulldog on the side of the vein to control the bleeding temporarily,
Great,
and artery can be ligated,
right,
identified
sir.
and
Correct.
ligated. Yeah.
In the same way, do you agree that if the kidney is completely flipped, quickly putting a gauze
Yeah,
piece
yeah,
in
yeah.
the front,
Yeah, that can be
gauze
done.
piece in the front and
Front.
completely
Yeah, you
quickly
can
with
you
the
can
hand
put a
mobilize and feel the artery and pinch
artery
it
and
and then
pinch
go
it.
for it?
Yeah, that can
That
be
is
done.
also
That can
life-saving,
be done.
especially in
That can be
laparoscopy.
done. Yeah,
Flipping of the complete kidney go to the retroperitoneum, the vein
that
will
can
not
be
bleed
done.
that much, and you can go it.
Recently,
Rajaraman.
recent.
Yes, sir. Yes, sir. Please tell, sir. Ravichandar, sir.
Recently, we were doing a partial nephrectomy where vein was torn. So
Sir.
we could apply bulldog on the lateral wall of where it was torn, and I could put the sutures on it.
Yes, sir. Sir,
Yeah.
Rajaraman, sir. Sir, now in difficult cases, the colon and the duodenum will be there. In the previous era, 30 years back, 40 years back, do you recommend bowel cleansing methods before doing a complicated ZPN? I don't remember that in my MS days that any bowel preparation is given. Do you usually give a bowel preparation or no? Unless the bowel is used for the reconstruction, normally.
Generally, we give, sir. Generally, we
give,
give
sir?
bowel preparation so that the mobilization of bowel be easier, sir.
But sometimes they say paralytic ileus will come and bowel will get distended.
That is better than having injury during the surgery, sir.
Okay. Sir, by chance, if the duodenum is injured during right side nephrectomy, what do you do, sir?
Sir, in this surgery, I want to say one word, sir. There should not be any ego, as Professor said. Ego and consulting others. If a dual injury is there, I'll definitely call a gastroenterologist and help me, sir.
This is a very
There should be
important
ego
message.
at all, sir.
Very important message to the juniors in the present era. Please don't repair however good you are and
Yes,
however
sir.
easy it is. Involve the surgeon officially and you either guide or together you do it. But their notes, their opinion, post-operative rounds, post-operative care
Yes.
is essential. Otherwise, legally it is not a correct point.
As
But
Gupta said,
otherwise,
it's a teamwork, sir. It
yes,
should be
sir.
team. No ego, sir. Certainly.
So otherwise, what are the precautions? Do you identify the duodenum in difficult cases of nephrectomy? Always mobilize it with right angle and then separate it and do, or there is no need?
No, we should try to separate gently, say with the right angle and non
Localization is
vascular. We should
essential.
gently separate. It depends on which condition you're tackling, inflammatory or tumor. We gently should separate. The tumor generally it will be easily mobilized.
Yes, sir.
Only
Yes,
the
sir.
problem comes inflammatory pathology, sir.
Sir, I have
Then you
not
go
touched the
subcapsular plane.
tuberculosis. Have you ever operated on tuberculous kidney, sir? We
Yes, sir.
rarely see.
Operated.
Nephrectomy in
Yes.
tuberculous kidney, what are the problems?
Same, sir. Same problem as xantho SGP.
XBN.
Adherent go subcapsular plane, sir. If it is, I'll try controlling the pedicle posterior. Step 1, sir. Step 2, I'll make a small incision. I'll feel the artery. And if I'm able to catch, well and good. Step 3, I'm not able to feel anything. I give a mass ligature and clamp, sir.
Clamping. Sir, if anything is going infiltrating to the psoas, whether it is abscess or tumor, how much you can dig into the psoas on the table to get out of the palliative or something like nephrectomy, which is for inflammatory disease? You don't mind removing some psoas muscle, get a plane and remove everything, or you leave it?
No, sir. I will not meddle with the psoas muscle, sir. I'll wait for histopathology. But if it's inflammatory, I will not try to dissect psoas muscle, sir. I will just remove the tissue as much as possible. Then wait for the histopathology report, sir. It depends on inflammatory and malignancy. Malignancy also can infiltrate.
Sir, one tough question which we used to be asked in the exam. If a large lymph node is there between the artery and vein, you are struck and vein is very thin stretched and a large lymph node during radical nephrectomy is there. This is very tough even in laparoscopy unless you flip and easily get it. And a bunch of lymph nodes, not really. Sometimes artery going through the lymph node tissue. How do you do in open surgery, sir?
So what I do is again I plan. If I'm able to dissect gently, I will remove the lymph node. If I'm not able to, I'll take a wedge biopsy and come, sir. I will not harm.
Anybody wants to take Gupta, sir? You want to take in a difficult. Some people say you pass there is a paper. You pass a silk thread behind the vein, and then you bring back on the psoas. Tie it before you do it. Completely tie it. After that, you cut the vein and then handle the artery. Or as you said, angioembolization before the surgery when you are anticipating CT, because CT is there since long time. Gupta, sir, comment on a lymph nodal mass between the or encasing the renal artery.
No, if lymph nodal mass is there and it is inoperable, means you are not able to separate it out unless you injure the vena cava or aorta or renal artery.
Sir.
In that case, I think so. It is only for the prognostic purpose.
Yeah.
You should take a biopsy and come out actually.
Great, sir.
And nowadays we have got TKI and all these things are available.
Okay.
So there is no need to worry
So
too much.
don't put a dissection if it is inoperable in the area of vascular regions just for the sake of removal. Quit and come out is also better option so that at least mortality will not happen. Is it the message, sir?
Yes.
So Jagadishwar, sir, you also make any comments on this discussion? Unmute, sir. Unmute, sir. Unmute, sir. Unmute. Unmute, sir.
Yes, sir. If the lymph node is mobile and proximal to that, the vessels can be dissected well, then we'll take out the lymph node. But if it is fixed very much and great vessels, it's fixed to the great vessels also, aorta and inferior vena cava, then as Gupta sir said, we take a biopsy and then close it, sir.
Sir, we will quickly take questions, not many questions, but anybody can answer. I don't specifically ask. Small rent in peritoneum, what to do, sir? Rajaraman, sir.
After
the surgery,
the kidney bridge down,
roll.
putting the kidney bridge depends on the size of opening, sir. And it depends on what tumor size you are, what it is, malignancy, inflammatory. If I'm able to close our kidney bridge, I'll be able to close it, sir. Close the peritoneum as far as possible.
Yes, sir. Now, next question. Where to open the peritoneum if at all you wanted to open? Ravichandra, sir. There is nothing big in this question. Sorry to confuse you. If I don't want to open the peritoneum, where will we open, sir?
Anteromedial to the colon, we open it and make sure that the whole colonic course is appreciated, and then lift up the colon with the help of the rent that we made in the peritoneum, sir. It's anteromedial to the colon.
Anteromedial to the colon.
Yes.
Somebody asked Anuj Yadav, in TB kidney for simple nephrectomy, is it necessary to avoid going transperitoneal to avoid risk spread? As much should we avoid? What do you say, sir? Mutulata madam, in TB kidney, if you suspect, will you avoid contamination by opening the peritoneum?
Definitely, sir. We'll go retroperitoneally, we'll remove it, sir. We need not open the thing.
Yes. In case of large tumors crossing midline, how to identify which side renal vessels are located? Srinidhi Janraman, I'm not getting this question. Frederick Paul, sir, in a tumor which is crossing and going to onto IVC, onto the or the renal, the aorta, what are the things you will recommend, sir? Frederick, sir.
Mobilize the kidney, mobilize the tumor all around, and the tumor will be hanging on to the vascularity. In
Yes.
that you can identify the vessels.
Yes, sir.
I don't think it is that difficult.
Yeah,
Because
there
the
will be
tumor,
plain in tumors, there will be plain.
Yes.
Sir, one more question to Madhappa, sir. People usually say if you want to be safe in renal surgery, dissect below, dissect above hilum, make spaces so that in emergency you can apply the clip. If you have not done above, if the bleeding starts from below, there is a problem. What is your message on that, sir?
Yeah, that is a safety thing, but you can always manage even if you are dissecting from only one side. Generally, we go from below only, don't go to the upper part. If there's bleeding, we can always handle it. There are various methods, especially in open surgery. You can use your fingers, you can use bulldog, you can use some the rescue stitch also. You can use in open surgery if you want to use it.
Sir, Rajaraman, sir, in again question asked by the SS 20.17, name is not there. In trauma nephrectomy, flank approach or midline laparotomy, which is better, sir?
Always should approach midline, sir.
Midline.
Midline. There are two
Very
reasons. Other
important
injuries you
because
can see, sir.
other injuries can be taken care.
Yes, sir.
Splenectomy or any injury.
Yes, sir. Liver injuries, bowel injury, duodenal injury. Always midline, sir.
Chandramohan.
Yes, sir.
Just one comment. The midline approach will avoid you opening the retroperitoneal hematoma if you do not want to open it. If
Yes,
you
sir.
go by the flank approach, you are directly opening the hematoma. Because many times in renal trauma, we may open and we may not do the nephrectomy also.
No, sir. Sorry, sir. You are very senior. But when you are doing open for any renal trauma, there should be a high chance of landing up in nephrectomy. Either
Yes,
you don't open.
No, what I meant to say is, if you open, you find that the retroperitoneal hematoma is not pulsating, not increasing, and patient is stable, you may not do nephrectomy. That's what I'm saying. May not.
Yeah.
May not.
So what do you say, sir? Transperitoneal or retroperitoneal?
Transperitoneal midline.
Okay, answer is that. So
Yes.
that other injuries, whether it is open, the hematoma or not, it is a personal choice. By the time CT is seen, you already know that what you are doing. So maybe for other reason, if you have done, don't open the gerotas. Leave it and come out.
Yeah.
Fine, sir. One person from Srinidhi asked how to manage aberrant lower polar vessel causing PUJ obstruction. Mutulata madam, when you do PUJ, retroperitoneally when you do, the problem of the crossing vessel should not come. What do you say, madam?
Yes, sir.
Only transperitoneal laparoscopy people inadvertently can cut. But retroperitoneum, that question doesn't arise because the vessels will be anterior to that, in fact. So we may not come across this. Now, the role of angioembolization preoperatively discussed by Prashant Mulwakar, sir. Actively, Prashant Mulwakar, sir, is participating in the discussion. I must thank him. Sir, Menpi Gupta, sir, in your practice, when all the facilities are viable, when large tumors are there, when will you recommend angioembolization? When will you do the surgery after angioembolization? When will you approach between the IVC and the aorta on the right side for the right renal artery? These three questions, sir.
See, we normally do embolization day before, and next day morning we take up these patients for surgery. So that is the standard practice which we are following for many years. And the other question you asked about if you are dealing with a large tumor, especially on the right side, then definitely you have to first go to the artery between the aorta and vena cava and try to take care of the artery there and ligate the artery there. That will make your life much simpler. Don't start dissecting on the kidney side.
Sir, yes, sir. With this,
One thing more I want to add here in this discussion,
sir,
in difficult nephrectomy, and that question was asked when your kidney can displace all these structures here, there. At that time, it is very important to recognize the origin of the artery laterally. Always remember that renal artery arises laterally. We have seen cases where hepatic artery, which comes out from the midline, that has been ligated during
yeah,
nephrectomy.
sir,
So
sir.
these kind of problems can happen. Just to remind that
Yes,
you
sir.
always see the orientation, the arteries arising laterally from the aorta.
Yes, sir. With this, we will give 10 minutes to the seniors who wanted to comment, because I know panelists are very experienced. Apart from that, people like Krishnaswamy Kannan sir, some of the seniors are there. In fact, Rajendra Nerli sir, President ASU, they are all very experienced. You can give quick comments on any subjects, but one by one, when one is speaking, please avoid the other person to speak. 10 minutes, we'll take the comments, no more questions. After that, Krishnaswamy Kannan sir, please.
Okay, I got only one point. It's a very good session you've done. Only one point I want to say. Do you people remember the name Gibbon?
Yeah, Gibbon.
Gibbon's catheter. Okay. Gibbon used to make a very, very important statement. There are two statements I remember, passed down to me by Dr. K.C. Reddy, my godfather. The wounds heal from side to side. They don't heal from end to end. So don't worry about the length of the incision. Many people think by making a short incision, they are made a bigger surgeon. No. Length of the incision doesn't make any difference.
Great, sir.
A lot of other things have been told, so I don't want to repeat.
Yes, great, sir. That is wounds, Ilangavan, wounds heal from side to side, not by lengthwise. I did not hear. There, Dr. Kumar Prabhu sir is also there. Prakash sir are there. Please speak out, sir. We'll be happy, because these are recorded sessions. We'll be happy to know from you people. Ilangavan, Prakash sir, Kumar Prabhu sir, any, or else you can share any rare untoward side effect in open surgery, how you managed. For example, large PUJ, what will you do? Decompression. Sometimes large things due to tissues compressed, we may misunderstand and cut it. That's a problem. Anybody?
Chairman, can I make one more comment?
Yes, sir. Please, sir.
Okay. In adrenals, it's always safer to be ready for a thoracoabdominal. It's always safer, especially on the left side. It is always safer to be ready for a thoracoabdominal.
Can you explain how thoracoabdominal incision is given, sir, please?
I go by the 10th rib.
You go by 10th rib and open the diaphragm.
Diaphragm, yes.
Cut everything that come across yours.
Yes, you will be very safe if you are handling the left pheochromocytoma by open, by a thoracoabdominal. Instead of trying to avoid opening the diaphragm, you'll be really struggling sometimes. So be prepared for, and as I already said, you can get the help of the cardiothoracic surgeon to close the diaphragm, if need be, to put the ICD and all that. But be ready for the thoracoabdominal incision for left adrenal tumor.
Sir, in the team, does anybody has done nephrectomy following PCNL bleeding, which is rare? Will there be any difficulty or nothing much after PCNL nephrectomy? Anybody has experienced?
Yes, sir. Early days we did have, sir.
Okay.
We did have early days, not now, sir. Early days. Those big sheets were used. They used to tear the renal injuries to grade 3 to 4. I had experience. I did an nephrectomy when somebody else did a PCNL, sir. Early days, sir, not now. And bigger sheets were used.
Nerli sir and Dr. Changal Rayan sir, president and past president, any comment? Changal Rayan sir also is very senior in Madras Medical College, and he's there, sir. He's there behind Rajaraman sir.
Yes, sir. I'm missing only thing. The background is blurred. I'm on.
No problem, sir. No problem.
No,
it's okay, sir.
Thank you, Dr. Chandramohan. Wonderful session. The way it is designed, the way the questions were, and the way the people who were answering were absolutely fantastic. Dr. Muttalata ma'am and Dr. Rajaraman sir, both of my teachers. Actually, I still remember the days how they taught us how to open, how to put an incision, how to open the ribs, and how to make a peritoneal elevation, periosteal elevation, how to dissect the kidney. Rajaraman sir used to take a pad and push the pad between the kidney and the diaphragm. That's how the upper region of the kidney gets separated from the diaphragm. And that is a wonderful technique which I learned from him. So
Very
this is something which I would like to add here.
Very good, sir.
Final comment, sir.
Yes, sir.
In this occasion, open surgery, sir, we should never forget our OT sisters, sir. Theatre OT sisters, they are unforgotten heroes. Without
We
them,
never forget, sir. Why will we forget?
I'm just telling, sir, we should thank them, sir. Because they have to tackle the moods of the surgeon, they have to see the instrument counts and all, very difficult, sir. Pad count, gauze piece, they are really unforgotten heroes, I mean, generally. But we should never forget them, sir.
Agree, sir. Agree, sir. Anybody want to comment? Otherwise, we'll conclude the session in 1 minute time.
Chandramohan.
The last point, what Dr. Rajaraman said, I think so. The needle count, sponge count is very important. And we have seen patients who have been operated by open surgery, and
Sir.
later on they come back with the leftover sponge with the formation of the pus and all that. So I think so. What he's saying is nurses, their role is very important. Don't close
Correct,
the
sir.
abdomen unless they give you the clearance.
Correct, sir.
One example, sir.
Sir.
Those days, no CM. One artificial miss, they'll panic. We'll also panic. So we should shift the patient down, X-ray room, then bring the patient up, sir. They play a very important role.
Sir, one question in this
Or
relevance.
you can use a magnet also, sometimes.
Yes, sir.
If you
Yes,
want to
sir.
punch a needle, you
Yes,
can put
Yes,
take a
sir.
magnet, Israel it and put it in the abdomen.
Yes, sir. We did all that, sir.
Sir, in a lying position, if you wanted to do X-ray on table, what are the methods, sir, Gupta, sir?
No, you have a portable machine, and you can, if your patient is on lateral position, on one side you can put the X-ray, another side you can put the beam, and you can take. In supine position, you put on the below the patient and take the X-ray.
You used to do that, sir, previously?
Yeah. We always
Large
sometimes.
stone burdens. Nerli, sir, any comment on anatrophic nephrolithotomy? President, sir, have you ever done what is the it may be less, but it looks beautiful surgery to cut the kidney on the border of the broadels, way open and take out stone and then suture. What are the implications? Nerli, sir, you wanted to comment?
I have no experience regarding anatrophic.
Anybody wants to comment anatrophic nephrolithotomy open?
No, we have done anatrophic nephrolectomy earlier for a staghorn stone with multiple calculi. And I think so it is one of the good operation. Only precaution you have to take, you have to dissect out the complete kidney. You should have the arrangement for the cooling of the kidney intraoperatively, and then you can make the incision and take out the stones. And at the end, obviously, you will leave a nephrostomy cath.
I have seen Dr. George P. sir presenting warm ischemia time anatrophic nephrolithotomy cutting in the avascular plane and take out the stones. He had series of 7-8 cases presented many times in South Zone. Unfortunately, sir is not there, but he is very good in anatrophic nephrolithotomy. Mutulata madam, you want to comment on nephrotomy incisions?
During anatrophic nephrolithotomy,
Yeah, anything, even renal stone surgery, nephrotomy.
Yes, sir, because we used to do at that time usual pyelolithotomy or extended pyelolithotomy, and you have to create the Gilvan plane. That is very, very essential, so that you can have the up to minor calyx, you can go with the gas, so that you can very well visualize and you can do the nephrotomy and you can remove the stones with the extended pyelolithotomy.
Sir, Kannan sir, please, sir.
Yeah, you're asking about anatrophic nephrolithotomy. Actually, for anatrophic nephrolithotomy, I have done many. Before the PCNL days, I have done many. We used to put a sterile plastic sheet to protect the rest of the body from the thing. I used to get the ice slush already ready and clamp it and put the ice slush. Then next few minutes, 3 or 4 minutes later, look for the Brodell's line, make the incision. But the most important point is after removal of all the stones, you feel for all the stones, removal of all the stones, the most important step in that is calicography, where all the small calyces are opened up and it is made into a small cavity. That is very important. And That experience of doing anatrophic nephrectomy helped me when I started doing partial nephrectomy open. There also I used to put the slice, the sterile cover, and then clamp, all that which I learned in anatrophic nephrectomy, I used for the partial nephrectomy.
Yes, sir.
Later now people are doing without cooling the kidney and all that. But it is always safer to do the partial nephrectomy or anatrophic nephrectomy with cooling of the kidney and clamping.
Rajaraman sir, I will ask again. Thank you, sir. Kannan sir. If any ureter, this may be the last question, if no questions. If the ureter is avulsed during pylolithotomy, or if anybody while doing URSL comes with an avulsion of the ureter, what will you do, sir? Please.
Depends on where the avulsion is, sir. Suppose it is VUJ. Those days we used to have bulb ureterogram, X-ray, used to inject contrast, then take.
Yes, sir.
Where exactly?
If the ureter is avulsed
Which area,
on table open surgery, while removing the stone,
yes,
only pelvis gives away and it is outside. Ureter is separate.
yes.
So the pelvis gets retracted. It is very difficult to suture end to end. What should we do, sir?
Then anastomose, suppose having enough little mobilized, anastomose to the hilar region of the renal pelvis, sir.
Okay.
Keep a stent. It happened. Usually avulsion happen at the level of pelvis, sir. When you do a lot of big stone, the pelvis get avulsed. Posterior there will be vessel.
So you prefer primary end-to-end anastomosis with nephrostomy, sir?
Pelvis to the renal pelvis ureter to the hilum of the kidney, fascia of the, and keep a stent, sir. And necessary, I keep a nephrostomy also, sir.
Yeah.
Yes, I've done that.
Chandramohan, I had an experience.
Yes, sir. Ramchandra, sir, please.
Yeah, while doing PCNL, pelvis got avulsed. One of my PG was doing PCNL.
Sir.
Pelvis got avulsed, and we have immediately opened and sutured to the capsule at the hilum, all around with interrupter sutures. And we have, after stent removal, we have done IVP. It was very good.
Very good.
If vascularity is good, pelvis vascularity is good, if you suture even to the capsule, that will take up.
Oh,
capsule should suture, hilum capsule.
Yeah.
Very nice.
Yes.
Very nice. So, dear friends and seniors, colleagues, I thank Dr. MP Gupta, sir. Can you imagine for last 30 years, he is teaching. If I have not to mention age, more than 80 years, sir is very active and very, very enthusiastic. Every answer is coming from his bottom of the heart. And we are thankful that he accepted and he stayed for 1.5 hours. And Dr. Jagdishwar sir, who is elected SU's president, joined irrespective of his busy schedule. In fact, we requested Ravindra Sabnis sir, and in his absence, then Jagdishwar sir kindly accepted and made this possible. And the panelists quickly answered. Nobody extended their explanation beyond the time. That was my concern. But you are all seniors, cooperated so well. Dr. Madhappa sir from Mysore, Dr. Muthulata madam Chennai. I asked many people in Chennai. They all told Muthulata madam is very good in open surgery. That's the greatness, madam.
Thank you, sir.
Your students will remember. Paul sir, silent, calm, and I came to know through the Kerala Society that he is very good open surgeon. Ravichandra sir, since long time, because I feel government institutions, HODs, are existing gods, not emotional, but true, because they teach our students. In fact, tomorrow our children also will be taught by them. They are silent. They don't project in the conferences. They will be at the just observing and learning and going. One among them is Ravichandra sir, who is very simple at heading one of the largest government institute in Hyderabad.
Thank you, Chandramohan.
Rajaraman sir, not to mention too much, Changol Rayan sir used to say that he is my teacher. When I met in ASU, he was appreciating me and the council, the way it is conducted. Always good heart to appreciate with vast experience. I thought Changal Rayan sir is very senior, but he is learning the sponge putting behind the kidney and pushing the diaphragm. I can imagine how senior he is, but you look fit for your for seniority. I really appreciate that, sir. And I thank all the audience. Now also around 85 audience were there. So overall 124 was the highest. Probably in ASU webinars, this is the largest gathering. That means still people are interested to learn what they don't know. Many youngsters don't know the open surgery. Probably they might have joined. Anybody wants to comment? Otherwise, Nerli sir will give the conclusion comments, sir, please.
Comment, sir. About Changal Rayan, sir. He looks very demure, sir. He's an excellent surgeon. SP transplant. He has done a cadaver transplant just 2 days back.
Yes, sir.
With very good result. He's an excellent surgeon, but he keeps quiet, sir.
Yeah, good, sir. All the government institution HODs, They don't try to this thing, but this is good for the society.
Yes,
Sir, Murli sir, you wanted to comment on the conclusion?
Yeah, this is one of the, I think, I too agree with that. That is one of the best webinars we have had in recent times. And I thank all the panelists and all the people who have contributed so richly to this discussion today. Thank you very much from my side.
So with this, thank you very much, sir. Thank you all of you for joining this session and making it lively. Thank you.
I'd like to make one comment.
Yes, sir. Yes, sir.
Thank you very
Chandra.
much for inviting me, because it reminds me old days when I used to go as an examiner to Gandhi Medical College, from Madras Medical College. Dr. Lata used to be there.
Yes, sir.
And
Thank
they
you.
were all
Thank you
lecturer
so
or
much.
something, like that. But I'm very happy to participate. And I think so this has been a wonderful session. And I think so we should not forget about the open surgery. That has to be learned by every urologist. Thank you very much.
Thank you very much, sir. Thank you all.
Thank you,
Thank you,
sir.
sir. Thank you, gentlemen.
Thank you.
Thank you.
Thank you all.
Thank you, sir.
Thank you. Bye-bye.
Bye-bye, sir.
Good night.